The last talk, we built sensitivity and specificity from the 2x2 table and established that these are properties of the test. They describe how the test performs in truly diseased and truly disease-free animals. And critically, they do not depend on prevalence. But here's the problem. When a client looks at you after you've run a test and asks, "So, doc, does my dog have it?" Sensitivity and specificity can't directly answer that question. They're population-level test descriptors. What the client is asking is a patient-level question. Given that this test came back positive, what is the probability that my animal actually has the disease? That question is answered by predictive values, and predictive values do depend on prevalence, which is why the same test with the same sensitivity and specificity can give you very different information depending on the population you're working in. That's what this talk is about. Here's the conceptual shift this talk is built around. Sensitivity and specificity answer questions about the test. How well does it perform in sick animals? How well does it perform in healthy animals? They're calculated down the columns of the 2x2 table, and they don't change when you move from one population to another. That's their strength. Predictive values answer questions about the patient. Given this result, what does it mean for this specific animal in this specific population? They're calculated across the rows of the 2x2 table, and they absolutely do depend on prevalence, which is both their limitation and what makes them clinically essential. Positive predictive value, PPV, answers, if the test is positive, what is the probability the animal truly has the disease? Negative predictive value, NPV, answers, if the test is negative, what is the probability the animal is truly disease-free? These are the questions your clients are actually asking, and these are the numbers you need to be able to calculate and explain. Formulas are straightforward once you remember the direction of the calculation. PPV and NPV are calculated across the rows, not down the columns like sensitivity and specificity. PPV equals true positives divided by all positive tests. TP divided by TP plus FP. It answers, of everyone who tested positive, what fraction actually has the disease? If PPV is 90%, then 9 out of every 10 positive results are true positives. If PPV is 20%, then only 2 out of every 10 positive results are true positives. The rest are false alarms. NPV equals true negatives divided by all negative tests. TN divided by TN plus FN. It answers, of everyone who tested negative, what fraction is truly disease-free? If NPV is 99%, then 99 out of every 100 negative results are true negatives, a very reassuring test to rule out a disease. One important note on interpretation. PPV and NPV are not just about test quality. They're about test quality and the prevalence of the disease in the population being tested. The same test will have a very different PPV in a high prevalence versus a low prevalence population. This is the single most important concept in this talk, and we're going to demonstrate it with numbers right now. Let's work through a concrete example. We're in a cattery with a known FELV outbreak. The prevalence in this population is 40%. 40 of our 100 cats are truly infected. We're using an ELISA with 95% sensitivity and 97% specificity. Building the table. TP equals 95% of 40, which is 38. Fn equals 40 minus 38, which is 2. Tn equals 97% of 60, which is 58.2. We'll round to 58. Fp equals 60 minus 58, which is 2. PPV equals 38 divided by 40, which is 95%. This means that in this category population, 95% of positive ELISA results are true positive. That's excellent. If a cat in this category tests positive, you can be 95% confident it truly has FELV. NPV equals 58 divided by 60, which is 97%. If a cat in this category tests negative, there's a 97% chance it's truly FELV free. Both predictive values are excellent here. That makes sense. In a high prevalence environment, a good test performs very well in both directions. Now let's take the exact same test and move it to a completely different population. Same test, same sensitivity, 95%, same specificity, 97%. Completely different population. Now the prevalence is 1%. Only one of our 100 cats is truly infected. Building the table, TP equals 95% of 1, which is approximately 1. FN is approximately 0. Tn equals 97% of 99, which is 96. Fp equals 99 minus 96, which is 3. PPV equals 1 divided by 4, which is 25%. That means in this low prevalence population, only 1 in 4 positive results is a true positive. 3 out of 4 positive tests are false alarms in cats that do not have FELV. NPV is approximately 96 out of 96, which is essentially 100%. A negative test in this population is extremely reassuring, which makes sense because the pretest probability was already very low. This is the most important number comparison in this entire talk. Same test. Prevalence drops from 40% to 1%. PPV drops from 95% to 25%. This is not a flaw in the test. It is mathematics, and it has profound clinical implications. If you test a low-risk indoor cat for FELV because the owner happened to mention they found a stray outside and the test comes back positive, you should not immediately tell that owner their cat has FELV. You should understand that in a low prevalence population, 3 out of 4 of those positives are false alarms, and you should recommend confirmatory testing before delivering that diagnosis. There's one more concept closely related to predictive values that we need to cover: the distinction between true prevalence and apparent prevalence. True prevalence is what we really want to know, the actual proportion of animals in a population that have the disease. Apparent prevalence is what we actually measure, the proportion that tests positive. These two numbers are almost never identical because almost no test has perfect sensitivity and specificity. If a test has imperfect sensitivity, it misses some true cases, so apparent prevalence will be lower than true prevalence. If a test has imperfect specificity, it falsely calls some healthy animals positive, so apparent prevalence will be higher than true prevalence. In most real-world situations, both errors are happening simultaneously, and their net effect depends on the relative magnitude of the two. The correction formula on this slide allows you to estimate true prevalence from apparent prevalence, given known sensitivity and specificity. You don't need to memorize the formula for most clinical applications, but you absolutely need to understand the concept, especially if you're doing surveillance work or interpreting herd-level test data. Why does this matter? If you're using a surveillance program to estimate how much of a disease exists in a population to make control decisions, prioritize resources, or report to regulatory agencies, and you're using a test with imperfect specificity, you will overestimate the true burden of disease. That leads to wasted resources, unnecessary interventions, and potentially incorrect policy decisions. Correcting for test imperfection is not optional in serious surveillance work. This table and graph summarize the relationship between prevalence and predictive values in a way I want you to internalize, because it's one of the most practically important things in all of diagnostic epidemiology. Look at the PPV column. At 1% prevalence, even our excellent test, 95% sensitive, 97% specific, gives a PPV of only about 25%. At 5% prevalence, it's 63%. At 40% prevalence, it's 95%. The test has not changed. The prevalence has. Now look at NPV. It's high across almost the entire prevalence range for this test. At low prevalences, a negative result is almost certainly a true negative. As prevalence gets very high, NPV starts to fall because now missing a truly infected animal becomes more likely. The practical rule of thumb: in low prevalence situations, positive results need confirmation. In high prevalence situations, negative results need scrutiny. This isn't a criticism of the test. It's the mathematics of how probability works, and it's the reason clinical context is never optional when interpreting a test result. Here's the summary. PPV is calculated across the positive row and tells you what fraction of positives are true. NPV is calculated across the negative row and tells you what fraction of negatives are truly clear. Both depend on prevalence, which is the key difference from sensitivity and specificity. In low prevalence situations, positive results are mostly false alarms and need confirmation before you act on them. In high prevalence situations, negative results are less reassuring and warrant scrutiny. And apparent prevalence, what your tests report, differs from true prevalence because of imperfect sensitivity and specificity. Correcting for this is essential in surveillance work. In the next talk, we move to likelihood ratios, a more flexible tool for updating probability that doesn't require you to know the exact prevalence in advance, and that works beautifully at the individual patient level. These questions are intentionally set in the context of EIA, a federally regulated disease with serious legal and economic consequences, to reinforce that PPV calculations have real-world stakes, not just academic ones. Question 1, Population A, N equals 1,000, prevalence equals 10%. Disease present equals 100. Disease absent equals 900. TP equals 99% times 100 equals 99. FN equals 1. TN equals 99.9% times 900 equals 899. FP equals 1. PPV equals 99 divided by 99 plus 1 equals 99 over 100 equals 99%. In an outbreak setting with 10% prevalence, even a single positive test is almost certainly a true positive. The test earns its reputation here. Population B, N equals 10,000, prevalence equals 0.01%. Disease present equals 1. Disease absent equals 9,999. TP equals 99% times 1 equals 1. FN equals 0. TN equals 99.9% times 9,999 equals 9,989. FP equals 10. PPV equals 1 divided by 1 plus 10 equals 1 divided by 11 equals 9%. In routine surveillance at 0.01% prevalence, only about 1 in 11 positive results is a true positive. Even this extraordinarily accurate test, 99% sensitivity, 99.9% specificity, has a PPV of only 9% in a very low prevalence population. Question 2. You should strongly advise against immediate euthanasia based on a single positive result. With a PPV of approximately 9%, there is roughly a 91% chance this is a false positive. The appropriate next step is confirmatory testing. The USDA protocol for EIA requires confirmation of positive Coggins tests precisely for this reason. The regulatory framework itself is designed to account for the mathematics of a low prevalence setting. Question 3. This example illustrates a fundamental principle of surveillance program design. When testing in a low prevalence population for a high consequence disease, you must have a confirmatory testing strategy built in. A single stage test, no matter how accurate, will generate more false positives than true positives in a very low prevalence setting. Good surveillance programs use tiered testing, a sensitive screening test, followed by a highly specific confirmatory test. We'll cover this in detail in Talk 2.4.